make a distinction that I think is going to reframe how you see your staffing problem. There's a difference between being understaffed and running a model that requires more people than it can sustainably support. Those are not the same thing, but they feel identical from the inside. And because they feel identical, most hospital leaders solve for the wrong one. They hire and hire and hire again, and the problem doesn't go away because the model is still producing more work than any reasonable headcount can absorb. Today, I want to talk about what's actually driving that and what some of the most forward-thinking practices in our profession are actually doing differently. So here's the baseline. The dominant model in veterinary medicine is high volume fee for service, right? See as many patients as possible, charge per service, keep costs down, which means keep headcount lean. We are running appointments at 15 to 20 minutes, and then we wonder why our team is burning out. The model is actually the problem. And I say that as someone who's worked inside of it, built staffing plans inside of it, and watched it wear people down at every level. Here's what lean staffing actually produces in practice. A single call out breaks the day. Not just a disruption, but it breaks because there's no slack in the system. Everyone is already at 100% on a normal day. So when something goes wrong, which it's always going to go wrong, the remaining team absorbs it. And they absorb it without being asked, without extra compensation, and without any kind of acknowledgement that it was an unusual thing, right? Over time, that's not just a rough day. That's the culture. And the team internalizes that. They stop expecting anything different. They start planning their exit. There's also role utilization that compounds all of this. Your credentialed technicians went through years of education and training to do anesthesia monitoring, to run labs, to provide client education, to perform skilled clinical work. And a significant portion of them are spending a significant portion of their day restraining patients and doing tasks that don't actually require their credential. Staff are naming this on Reddit, on Facebook groups. They're calling it being a glorified restrainer. And that's not just frustration. It's an inefficiency. It's also, honestly, a waste of your most expensive clinical resource. If you're paying a credentialed technician and not deploying them at the top of their license, you're paying a premium for work that could be done by someone at a lower pay grade. And your technician knows it, so they're leaving. So what does that look like to run a different model? Because I don't want to just name the problem. I want to show you that it's being solved in adjacent industries and inside of our own profession. So in human medicine, there's a model called direct primary care. Patients pay a flat monthly or annual membership fee, and the practice maintains a much smaller patient panel. Smaller panel means longer appointments. Longer appointments means less volume pressure, which means the team isn't sprinting through every single interaction. That also means the client feels like they're getting more of their money's worth. The data on this model shows lower burnout rates, higher staff retention, and here's the kicker, higher patient satisfaction. Because when you're not running at a maximum volume, you can actually do the work. Veterinary practices are starting to pick up on this, right? There's subscription models that cover routine care for a flat annual fee. This isn't actually new, but we're seeing this more and more. So this gives you predictable revenue, predictable volume, and a staffing model that can actually breathe. Inside of our own profession, Veg has built something worth paying attention to. They lead with people before patients. And I know that can sound like a marketing line, but structurally it means something. It means that they've built a career pathway that is visible and accessible. It means they celebrate veterinary assistants with an entire dedicated week. It means their hospital design, the open floor plan, is intentional. It removes the back room, that mystique that creates distrust with clients and isolation among staff. And that's not by accident. That's design. It produces a different culture. I happen to have worked at Veg for some time. I don't currently work there, but I did work there. And I know some people who only ever worked behind the closed doors and have that icky feeling about an open floor plan, but you don't know what you don't know. And all I can say is don't knock it until you try it. If your argument is that you hate the idea because you can't curse, I'd encourage you to think about what you just said. Now, before I say what I'm about to say, this is coming out right after Chewy purchased Modern Animal. So things might look a little bit different soon, but as of right now, as of me saying what I'm saying, I can say that what I have seen Modern Animal do historically has been really interesting on the client-facing side. The subscription model, app first, digital estimates before services are rendered. The effect is that the cost conversation happens before anyone is in the exam room, before the emotional stakes are highest, which is actually a meaningful structural shift. All of this said, you're probably not going to rebuild your entire business model this quarter, and that's fine. But here's what you can actually move. First, do a real audit on what your credentialed technicians are actually doing all day. Not what the job description says, not what you assume they're doing. Shadow a shift or ask them to track their tasks for a week. Find out how much of their day is being spent at the top of their license and how much is spent below it. Then figure out what would have to change to shift that ratio. Maybe it's task redistribution. Maybe it's adding an assistant level role to handle lower acuity tasks. Maybe it's restructuring appointment flow so your technicians are doing their skilled work at the right point in the visit. This is not a complicated analysis. It's just a conversation that most hospitals haven't actually had. Second, build margin into your staffing model. I know that's hard. I know the numbers are tight, but I want you to think about it this way. What does a call out actually cost you? Not in the abstract, not just some random number, but what does it actually cost in staff overtime, in missed appointments, in team morale, in the likelihood that people who covered will not be back tomorrow at full capacity? Sometimes the cost of not having margin is actually higher than the cost of building it in. And once you run the math, the conversation with the ownership or your regional looks a lot different. Third, consider what you can tier. Not every service needs to be all or nothing. Not every appointment needs to run at the same pace. Look at your appointment types and ask honestly, where is the model creating unnecessary volume pressure? Where could you protect time for complex cases that actually need it? Some practices have had success ring fencing certain appointment blocks for higher acuity cases and building the rest of the schedule around them. It requires discipline. It also requires having an honest conversation about what your practice is actually trying to do well. And fourth, this is a leadership conversation before it's an operational one. If you want your team to stay, you have to build a practice where staying makes sense. That means role clarity. It means practicing at the top of their license. It means breaks that actually happen. It means a culture where asking for help is not a weakness. None of those things are free, but none of them are as expensive as turnover. Understaffed and the wrong model are not the same problem, and they don't have to have the same solution. If you're not sure which one you're actually dealing with, this is actually what the Clarity Leadership Assessment is designed to help you see. It's free, 14 questions. You'll find it at www.lvt.vet. If this is hitting somewhere specific for your practice, leave it in the comments. I want to know what you're working through. If there's a leadership or a management problem or pain point that you wish that I would go over, let me know and I will talk about that. I'll find a guest, I'll add them to the podcast. I want to talk about the things that are important to you. So leave that in the comments too. If you didn't already know, I'm Suzanne Thomas. This is Leading Veterinary Teams. Until next time, lead where you are, even when it's uncomfortable, especially when it's uncomfortable.